The human brain is surrounded by a rigid structure called the skull, which has virtually no ability to expand. In other words, the brain is literally boxed in. Then how is it that a patient can have a walnut-sized brain tumor and still survive? Well, it's because the brain contains three fluids that can be displaced to accommodate this expanding mass. These three fluids are, first, water, that's both interstitial and intracellular. Second is blood, and third is cerebrospinal fluid, or CSF. Two physiologists, Monroe and Kelly, established that within this intracranial volume, there is a balance among these three components, and a change in the volume of any one of them will cause a corresponding change in the other two, so that the intracranial pressure will always be maintained between the normal range of -5 to +15 millimeters of mercury. Anytime the pressure goes above 15 millimeters of mercury, we call that intracranial hypertension. Now, the brain has several compensatory mechanisms to alter the three components as the pressure begins to rise. First, CSF will be displaced into the cisterns, or deep fluid cavities within the brain. Secondly, blood vessels will constrict to decrease the cerebral blood volume to provide additional room within that crowded box. Now, what really determines then how fast and how far the intracranial pressure will actually rise? Well, the more volume you add, for example with a bleed or with a brain tumor, the higher the pressure is going to go. Secondly, the faster the bleed actually occurs, the less time the brain has to compensate. And lastly, the tighter the brain is to begin with, or how much give it has, the higher the pressure will go. For example, in a young child, when the brain is nice and full right up against that skull, there's very little give, so we consider that brain to be tight. But in the elderly or the alcoholic population, where the brain has actually shrunken, there is room to give, and so we consider that brain not to be tight.
The compliance curve illustrates this concept of limited compensatory ability. The graph shows the relationship of extra fluid or mass in the cranial cavity to the pressure buildup it creates. It also indicates why expectant observation is so important. For instance, one would assume that if the bleed expanded 10 cc's to 30 cc's, the resultant pressure would be 3 times greater. But as you can see, the bleed can continue to increase, and there is still no change in the intracranial pressure. That's because the brain is ridding itself of the extra blood and extra cerebral spinal fluid to compensate for the bleed. However, as the bleed increases, the brain reaches a point where it can no longer adapt to additional volume. If no recognition or intervention occurs at this stage, even a small increase in volume will cause a steep rise in intracranial pressure. As the increased intracranial pressure distorts the brain tissue, it inhibits blood flow and cerebrospinal fluid circulation and causes neurological symptoms.
The increasing ICP clinical picture is seen when the patient is on the A, or the flat part of the compliance curve. The impending herniation picture occurs on the B and C parts of the curve. It is absolutely critical to understand the different clinical presentations of a patient whose ICP is increasing from one who has impending or actual herniation. In order to get help as quickly as possible for these patients, let's take a look at what the increased ICP patient will look like in regards to those early vital clues.
The first assessment parameter and initial and most sensitive indicator of change is level of consciousness. This is the best place to look for clues that indicate a patient's intracranial pressure is rising. Be alert to the patient whose response is the same, but who requires increasing stimulation to get him to respond as before.
Neil, wake up, Neil. Neil, wake up for me. You open your eyes?
Also, note any loss of the detail you had gotten on earlier evaluations of orientation.
Open your eyes.
What?
I want you to wake up. I have a few questions for you.
All right. What?
Tell me where you are.
I'm in bed.
Okay, you're in bed. Tell me where. What place is this?
Hospital.
Can you tell me the name of this hospital?
You may note deteriorating speech patterns, or the patient may no longer speak distinctly, may slur his words, or make mistakes without realizing it, or use phrases instead of words.
Can you tell me what year it is?
1995.
1995. And what month is it?
It's July. July.
No, it's not July.
It's September. Is it September?
No.
It's September. No.
Try a little bit harder. I know this is hard, but you need to stay.
Finally, forgetfulness and restlessness are common, although a patient who may suddenly become quiet after severe restlessness should be thoroughly reevaluated. The pupillary response, or second assessment parameter, may also offer some clues. Pupil changes usually occur on the same or ipsilateral side of the pathology. If a bleed is on the right pupil usually changes. The early clues are a pupil that still responds to light but is sluggish when compared to the other side. Or the pupil will constrict but can't hold the constriction and will redilate even though the flashlight is still shining on it. This is called hippus.
I want to take a look at this arm first. Can you push me away here? Push, 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 push. Great. Now pull me in. Oh, wonderful. Let me take a look at this arm here. This arm
The
feels a
third
little
parameter
lighter
to
than
assess,
the arm
which
here.
changes with increased intracranial pressure,
Yeah.
is the
Push
motor
me away.
response.
Can you push?
Changes usually occur on the opposite side or contralateral to the lesion. Motor responses may be particularly revealing. The patient with increased intracranial pressure displays increased resistance early to passive movement, or may display a change in strength of 1 point or more. The test of strength is likely to show this patient with a subtle loss from 5/5 to a 4/5 at this stage. But any change is an important early warning. The onset of a motor drift is another early clue. A new tendency for a limb to drift after less than 15 seconds indicates early but increasing deterioration. Note changes carefully, report them promptly, and continue to monitor them frequently. Last, taking vital signs is still important, but seldom provides early clues that increased intracranial pressure is developing.
Everything that we've discussed so far applies to that period on the compliance curve when there is already some increased intracranial pressure. But the brain is making allowances for the bleed. Early detection of the clues that we've discussed, recognizing their importance, taking corrective action, and being prepared for and administering therapies are all essential until we can adequately control the increased ICP before the patient moves to the B area of the compliance curve. That's the point when the increased intracranial pressure begins to put the patient at significant risk. The B point is when the bleed has increased to where the box is so full that something must give. And unfortunately, that something is going to be the brain.
As pressure builds, the intracranial structures are compressed and may shift from one compartment to another. This is known as herniation and is a life-threatening complication. A sequence of critical events may occur: brain compression, the distortion of brain structure, vascular compromise, cerebrospinal fluid obstruction, irreversible brain damage, or even death. Herniation also usually means that the brain shifts downward, the area of least resistance, which puts pressure on the brain stem and its blood supply, thus compromising vital functions. To describe herniation another way, if the pressure inside the skull or box continues to rise, the brain tissue becomes compressed and squeezes its own blood supply, eventually causing tissue death. Unlike the early clues, which are subtle, the patient with impending herniation is readily evident. The patient has now become unarousable despite 30 seconds of painful stimuli. The patient now displays dense weakness in the opposite extremity. He may progress to posturing, or worse yet, show no response to any stimuli. The patient may display a unilateral fixed, dilated, or blown pupil, a true medical emergency. Motor response changes profoundly. When vital signs are finally affected, these are late, very late changes and are the body's emergency, desperate efforts to perfuse or send blood to the brain. Collectively, vital sign changes are called Cushing's triad. Cushing's triad is defined as increased systolic blood pressure, profound bradycardia, and abnormal respirations. Increased systolic blood pressure occurs because the body tries to force blood through cerebral vessels compromised by increased pressure. At the same time, the heart rate slows, allowing more blood to be sent to the ischemic brain with each beat of the heart. And finally, respiratory rhythm and rate are affected, as pressure on the brainstem triggers these abnormal patterns.
Why don't you go ahead and call anesthesia? Let's get a stat intubation.
Okay.
Call neurosurgery and let's give him some mannitol. Neil, buddy, let's wake up.
Anesthesia stat.
Neil, come on, wake up.
Somebody page neurosurgery.
Wake up, Neil.
Stat.
Come on. Let's get an
Okay.
oral airway. Let's get a mask and a bag. Come on, Neil, wake up. Come on,
At
Neil,
this
buddy.
point, the patient has reached C of the compliance curve, and his life-threatening situation has escalated dramatically, requiring an immediate effort by the healthcare team.
Need to mix up a gram of mannitol per kilo. Follow that with 10 milligrams of Lasix IV.
The treatment strategies for this crisis will focus on medically decompressing the brain to prevent further deterioration. This is best accomplished by working with the three fluids that we can displace: blood, water, and cerebral spinal fluid.
Hey, Kara, what's the problem?
This gentleman was in a car wreck yesterday and is beginning to herniate now. I think we need to intubate him for hyperventilation.
Okay.
The healthcare team can take 2 steps to decrease the cerebral blood volume. The first is to elevate the head of the bed at least 30 degrees. This elevation uses the force of gravity to allow venous blood to flow more readily from the cranium. The second step requires intubation to facilitate hyperventilation via mechanical ventilation. Hyperventilation is important because it increases a patient's rate or depth of breathing. Either of these blows off carbon dioxide, causing cerebral blood vessels to constrict, thus decreasing cerebral blood volume.
Normal range for carbon dioxide is 35 to 45 millimeters of mercury. Because we want the vessels to constrict, the goal is usually to keep the range for carbon dioxide at around 28 to 33. Too aggressive hyperventilation can cause the vessels to constrict too much, allowing too little blood to get to the brain and causing an ischemic event. It is also important to monitor pH during hyperventilation. pH should not reach more than 7.55. Careful monitoring of the oxygen level is critical.
Behind you.
All right, I have a tube ready, all right, Tony. All right. Okay, we got suction. Okay, let's get the lidocaine first.
All right.
And the fentanyl.
All right, here's 100 Lido.
Okay.
Okay, mannitol's in.
Okay, follow that care with the lidocaine. Okay, he's stable. Let me see his eyes.
The second fluid the healthcare team will attempt to displace is water.
Down, actually.
Diuretics are ordered to reduce water in the cerebral tissues. The patient may be put on a PRN or an around-the-clock furosemide order.
Okay.
Furosemide or Lasix is a loop diuretic given in small doses, about 5 to 10 milligrams every 6 hours. 5 to 10 milligrams provides a 200 to 500 cc diuresis, which is enough to decrease intracranial pressure without lowering blood pressure or causing a loss of potassium. Furosemide begins to work in about 15 minutes and lasts 4 to 6 hours, the same as another diuretic, mannitol.
Mannitol is an osmotic diuretic, or a very concentrated solution. Serum osmolarity, in simple terms, tells us how concentrated the blood is. With hyperosmolar therapy, we aim for the serum osmolarity, or serum osmo, to be between 310 and 315 milliosmos, with 285 to 295 being the normal range. This should be sufficient for an osmotic gradient to pull fluid from the cells and the interstitial spaces into the intravascular space, where it can be removed. The serum osmo should not be allowed to increase beyond 330, because the patient will likely experience renal failure or other complications. Mannitol is given at 1/4 to 1 gram per kilogram. It works very quickly in just about 15 minutes and can last up to 6 hours. Remember, though, that there is still a rebound effect with mannitol, so some institutions are trying to achieve the same hyperosmolar effect by using instead a 2 to 3% saline solution.
I was in a car wreck yesterday, and this morning had a CAT scan that showed a big right temporal lobe hematoma with midline shift and early hydrocephalus.
He's herniating now?
Yeah, he's just extending.
An ongoing challenge even during the emergency resuscitative effort. is preventing secondary injuries. These are harmful, potentially brain-damaging events, which are unrelated to the initial neurological injury or problem. The most common of these are hypoxemia, hypercarbia, hypotension, and hypermetabolic events. You can usually prevent secondary injuries such as these by simply remembering the ABCs. Keep the airway open, the patient breathing, and circulation optimal. The brain does not store oxygen, so whenever it is deprived of oxygen, it undergoes potentially irreversible changes within minutes. Monitoring the patient's oxygenation and ventilation by arterial blood gases or an oxygen saturation monitor is critical. And end-tidal CO2 monitoring is another critical assessment. The goal is to keep the PaO2 equal to or greater than 100 millimeters of mercury and the PaCO2 less than 35 millimeters of mercury. The patient's temperature should not be forgotten, even during this crisis situation. It is one of several hypermetabolic events which can act as a secondary injury. Fever increases the brain's demand for oxygen at a time when the supply can't be guaranteed. Fever is treated with antipyretics, fans, tepid sponging, and use of a hypothermia blanket. Research has shown that wrapping the hands and feet will limit the shivering that often occurs with use of a hypothermia blanket. Preventing seizures, another hypermetabolic event, must also be considered with patients who have a neurological insult or one with increased intracranial pressure. Loading the patient with 18 to 20 milligrams per kilogram of phenytoin is adequate to prophylax most patients. The serum level should be monitored to ensure the maintenance dose being used is adequately keeping the level within the desired range. IV phenytoin should be administered no faster than 50 milligrams per minute and is only administered in normal saline to prevent precipitation. Research has shown that keeping the patient calm helps minimize the demand for oxygen and glucose. If a patient is consistently restless, an order for sedation is obtained. The usual agent is a fentanyl drip. The goal is to keep the patient in an arousable state, but decrease the patient's ability to injure himself until his status improves. These management strategies for preventing secondary injuries can and should be used in any patient, but especially those with neurological diagnoses.
How are they doing? Is he doing about the same? Not moving.
Stable, little tachycardic.
Okay, let's have the drapes, please. Take this back. See the drapes.
The third fluid we can manipulate in treating the patient is the cerebrospinal fluid. Through a burr hole in the patient's skull, a neurosurgeon places a catheter into the anterior horn of the lateral ventricle. This allows us to drain excess cerebral spinal fluid in a very controlled fashion, as well as to measure the actual intracranial pressure. Keeping the patient's airways clear by suctioning is a must. Intensive coughing, increased blood pressure, heart rate, and intracranial pressure that frequently accompany suctioning can be blunted by the use of 2% lidocaine IV or via the endotracheal tube before suctioning. Preventing hypotension or ensuring an adequate blood pressure to perfuse the brain is an essential part of nursing responsibilities.
ABC's ready.
Blood, need more blood. Yeah, it'll be nice. This is a pretty bloody procedure, so there's a lot of blood. Okay, IVC, please. And water. Yep. Yep, I'm in. Show the edge of this water. Okay, stop. Yep.
Cerebral perfusion pressure, or CPP, is a mathematical number obtained when you subtract the intracranial pressure from the mean arterial pressure. It's like a pathophysiological contest between the intracranial pressure closing those vessels off and the mean arterial pressure trying to force those blood vessels open again. If the mathematical answer is greater than 60 millimeters of mercury, the blood pressure is winning and the brain is being perfused. However, If the number is less than 60, as we see in the second patient, the mean arterial pressure is adequate, but the brain is not being perfused. Knowledge of cerebral perfusion pressure offers a second option to sustain the patient while waiting for the other therapies instituted to work. The mean arterial pressure can be elevated to increase the cerebral perfusion pressure despite the continued elevation of the intracranial pressure. The mean arterial pressure is increased by the use of vasoactive drugs such as dopamine or entropin or phenylephrine or neosynephrine.
Nurses must always be alert for potential emergencies, then move promptly to meet the patient's urgent needs. By the same token, nurses must also be prepared to respond to the positive changes which usually occur in intracranial hypertension cases when properly treated. As research continues to unravel the complexities of intracranial pressure, the management and range of therapeutic and pharmacological intervention will expand. Finally, remember that patients undergoing neurologic changes are often anxious or frightened, even if they don't appear to understand. Addressing psychological needs by touch, a gentle voice, and frequent reassurance continues to be a vital part of nursing's role. Families also need these reassurances as well as opportunities to see their loved ones.
Recognizing the early clues and taking steps to lower rising intracranial pressure can make significant differences in mortality, and even whether patients can ultimately have some degree of a normal lifestyle. Patients and physicians absolutely rely on our ability to accurately assess and to recognize early changes, to articulate a clear picture of change, and to know what to anticipate in the way of treatment.